Hello, my name's Kori Zachrison. I'm an emergency physician at Massachusetts General Hospital and was one of the co-vice chairs of the 2026 Acute Ischemic Stroke Guidelines. And I'm joined by two of my colleagues from the writing group.
I'm Tracy Madsen. I'm also an emergency medicine physician. I'm at the University of Vermont Medical Center, and I'm also one of the writing group members.
And I'm Opeolu Adeoye. I'm an emergency physician at Washington University in St. Louis and one of the co-authors of the guidelines.
And we have the pleasure of sharing a few of the highlights from our perspective as emergency physicians from the new guidelines. We are planning on hitting the pre-hospital setting, thrombolytics, and thrombectomy. From the pre-hospital setting, a couple of the big highlights that are noteworthy are, one, an updated guideline related to mobile stroke units. The mobile stroke unit recommendation is that in areas where MSUs are available, we now have a level 1 recommendation for their benefit for patients who are eligible for thrombolytic. There is certainly a recognition that MSUs are not available in all locations, and the recommendation takes that into account and also recognizes that their benefit in hemorrhagic stroke and thrombectomy eligible patients is less clear. Another update from the pre-hospital space is related to destination management. This is a place where the guidelines really tried to take into account the nuance of different settings and different places and levels of resources that might be available. And so while the RACE-CAT trial was a really important piece of evidence to incorporate into the guideline, and in places where there are well-functioning systems of care, like in the Catalan area of Spain, the guideline takes that evidence and recommends direct transport to an initial thrombolytic capable center prior to transfer, if appropriate, for thrombectomy eligible patients. In other settings where the systems of care might not be as well organized and well functioning, there's a recommendation for direct transport to thrombectomy capable centers for appropriate patients. Tracy, I would love to hear from you on the thrombolytic updates.
Sure. So this is, of course, of critical importance to emergency medicine physicians when we're making decisions about thrombolytics in the emergency departments. So two main changes, two main updates to the guidelines. The first is TNK. So we all know a lot of our hospitals are already using TNK, but now it's in the guidelines. You can use TNK or alteplase, so tenecteplase or alteplase. And again, should be based on your local hospital protocols, but either is acceptable. And then the second really big change in terms of thrombolytic therapy is the time window. So this guideline extends the time window for thrombolytic therapy up to 9 hours for patients when you have perfusion imaging that demonstrates that the patient may potentially gain a benefit from getting thrombolytics. This is a big deal, and will have to, again, be tailored to individual hospitals and protocols. But this is great. It really expands the number of patients who may be eligible for thrombolytics and favorable outcomes ultimately.
And Opeolu, would you like to share a little bit of the updates related to thrombectomy and pediatrics?
Yes. So I think, to just take a step back as far as what the themes that I think are emergent are, I think that what the guidelines do is sort of offer hope for treatments for more patients than are currently being treated altogether. And so within the context of the pre-hospital example that Kori gave, getting patients to treatment sooner and facilitating that treatment within the context of Tracy's mention of expansion of thrombolytic benefits, we have an opportunity now to treat patients up to 9 hours. The evidence is not such that we all shall do this, but I think we can develop local protocols that allow us to treat patients that may benefit in a way that we weren't sure of before. And so similarly, with the pediatric situation, we recognize that most pediatric stroke patients actually don't arrive to the children's hospital. They in general are showing up to community EDs. And so we have to be able to recognize and identify that yes, children do actually have stroke. when we have a child with a stroke, then sending that child to a thrombectomy capable center is again offering hope to that child in a way that I think is new for the guidelines. We've never addressed this in terms of treating children, even though we all know children, unfortunately, periodically have stroke. And then within adult thrombectomy, we have many more indications, the large core indications, class 1 recommendations, people that we would have said we don't have a treatment option for. Now, by guideline, by level of evidence, we can again actually offer treatment to those patients. So overall, we're getting there. And I think it's just sort of increasing orders of hope, as I like to think about it, for a variety of patients that we take care of routinely in the emergency department.
Thank you. And one of the things that you were reflecting on earlier that I'd love to share as well is just related to, I think, how we were able to bring the perspective of emergency physicians to the writing group, and the sort of sense that all emergency departments are not created equally. And so if you want to sort of share a little bit more about your reflections there.
Yes, gladly. And I think, again, this is similar to the notion of where children show up. And the resources that are available in one ED versus another, the ability to get the CT perfusion images that we need for a selection of patients varies greatly from the rural emergency department to different levels of suburban emergency department to the quaternary hospital in most urban areas. So we just need protocols and we need systems of care to be able to support these treatments that are now, if we take a step back, for everybody, hopeful and available. But for the individual clinician, we really do need our systems to support that person depending on their practice environment in order to facilitate the care of these patients.
That feels like the perfect note to end on, is this reflection about the value of the system of care. Thanks, guys, for your time.
Thank you.